All right, it's time for us to have a much shorter lecture on the vessels, arteries and veins, and lymphatics related to the abdomen and the organs in it. So, the first thing is these first few slides, I don't want you to get overwhelmed by. These are basically a little hierarchical, nested list of the vessels that we're going to go through. And while you can memorize them, and that's actually something you want to be able to do, draw them out, list them in a nested way like this, what we're going to be doing for the rest of the presentation is basically walking through every one of these parent vessels and looking into all the different vessels that come off of it. So, for example, we're going to get to the superior mesenteric artery and look at all these daughter arteries and the daughter arteries of those arteries and so forth. So what I would worry about right now is have this list in front of you and kind of check them off as we go, but don't worry about memorizing this before moving on, because we're going to use this as a little bit of our list as we go through a tour of the abdominal vessels. Likewise, we're going to have a list of the paired vessels that go to various organs and structures in the body, and then finally the veins that are going both to the inferior vena cava and to the liver via the hepatic portal vein. So just have these in front of you, have them available, stop and check every so often that we're hitting all these and you get a sense of how the blood flow works. And then we should be able to answer any questions we have related to the blood flow, blockage of it, surgical intervention, and what vessels have to be dealt with when you're working in this area. So, deep breath. Never has this comic been more true than spring 2020. All right, let's go ahead and get going. So, if we take a look at the posterior body wall, what we see are the two large vessels. We've got the abdominal aorta and the inferior vena cava, and pretty much everything we care about is going to connect to those in one way or another. The hepatic veins are going to be where the liver drains its blood, and since the liver receives most of the blood from the abdominal organs, the digestive tract, as well as the spleen, all that blood will eventually work its way into the inferior vena cava via those hepatic veins. So let's take a look at the aorta to start with. Our big three unpaired arteries that go to the GI tract are going, the foregut, the midgut, and the hindgut are going to be the celiac trunk, the superior mesenteric artery, and the inferior mesenteric artery. And that's exactly how they're laid out. The celiac trunk supplies the foregut organs. The superior mesenteric artery supplies the midgut organs, and the inferior mesenteric artery supplies the hindgut organs. And there'll be a few places where they anastomose, and we'll draw attention to those as we go. So, deep breath in, let's talk about the celiac trunk supplying our foregut organs. So, what are the foregut organs? They are the distal esophagus, the stomach, the liver, the gallbladder, part of the duodenum, part of the pancreas, and our spleen right here. So here are the vessels we have to contend with. There's three vessels that come off the celiac trunk, and just be aware, in reality there is a lot of variation in this area, but I will be testing you as though this version in this presentation was 100% accurate all the time. But in reality, be ready to deal with occasional discrepancies in how the branching occurs. Anyhow, the left gastric artery comes off the celiac trunk and it's supplying the lesser curvature of the stomach on the left side. So gastric arteries go to the lesser curvature. Then we've got the great big and very coiled splenic artery. It stretches to the left posterior to the stomach and it's going to get to the spleen over here. There are some short gastric arteries that come off the splenic artery to supply the fundus of the stomach. And there's a nice big left gastro-omental artery that's supplying the greater curvature of the stomach as well as the greater omentum. So just be aware, gastro-omental is bigger than gastric, so gastro-omental takes care of the greater curvature, whereas the gastric arteries take care of the lesser curvature because they're a smaller word. That's not why, but it works out nicely. Next up, we have our third branch off the celiac trunk, the common hepatic artery, and it's going to stretch to the right. Now the common hepatic's going to branch to become the proper hepatic, which goes up to the liver, and it's going to have a few other branches in this area. Right here, the proper hepatic gives off the right gastric artery, so that's going to go to the lesser curvature of the stomach as well, and anastomose with the left gastric artery. Then we've got, continuing upward, a split, a left hepatic and a right hepatic artery. And off the right hepatic artery, inside this triangle right here, we're going to have the cystic artery. So I'm jumping ahead a bit, but that's what I do. Between the cystic duct and the common hepatic duct and the underside of the liver is where you're going to look for your cystic artery. It's an important landmark called the Triangle of Callot, and that's where you're going to look for that artery when you do a gallbladder removal. Also, coming off of the common hepatic, we've got a sometimes very short branch called the gastroduodenal artery, which has lots of other branches as well, one of which will be our right gastroomental artery. And just like the one on the left, it's going to go along the greater curvature of the stomach and supply it and the adjacent greater omentum. And it anastomoses with the left gastroomental artery right there. Now, it'd be nice if that were all, because that's a lot. But we have a few others that we have to see from a slightly different point of view. So once again, we've got the same vessels, but now we've lifted up the stomach and the greater omentum. Off the celiac trunk, we have the left gastric artery, lesser curvature, splenic artery, and there's that left gastroomental artery going to the greater curvature over here. We got some short gastric arteries coming off the splenic to the fundus of the stomach, and then here we can see a few arteries that weren't visible before. Off the splenic, we've usually got 2 or 3 vessels going into the pancreas. So into the body of the pancreas, we have the posterior or dorsal pancreatic artery, the greater pancreatic artery, and the artery to the tail of the pancreas. So they kind of lay out boom, boom, boom off the splenic artery, just like that. Over here, we've got that third branch of the celiac trunk, the common hepatic artery, giving off the proper hepatic, and now we can see a little more clearly how that gives off the right gastric artery to the lesser curvature of the stomach, and that gastroduodenal artery, which can be pretty short, but as it branches, it's going to give off a few different important branches. Now, we've got to go to the head of the pancreas and supply the duodenum as well, and that's going to be done by 2 superior pancreaticoduodenal arteries. And they actually wind up splitting to go on the anterior side of the pancreatic head and the posterior side of the pancreatic head, so they kind of straddle it. Also coming off our gastroduodenal is that right gastroomental artery to the greater curvature of the stomach. So know the names of the arteries, know the branching pattern, and then use the names to pretty much figure out where those vessels have to be. If it's gastroomental and it's on the right, well, it's going to be along the greater curvature of the stomach and the omentum on the right side. A little further in, we've now removed the stomach and can see the branching pattern slightly differently. So right here, we've got right gastric artery, splenic artery, common hepatic artery, and now we're going to follow the proper hepatic up to the left hepatic, right hepatic, and cystic artery, once again in that triangle. Here's the gastroduodenal artery. It often gives off a tiny little branch that goes to the superior part of the duodenum, the first part. It's called the supraduodenal artery. Sorry, supraduodenal if you're American, supraduodenal if you're Canadian. And then we're going to have the posterior and anterior branches of that superior pancreaticoduodenal artery. Now, because you're probably stir crazy at this point, go ahead and drive yourself nuts by listing these out fully. Anterior superior pancreaticoduodenal artery versus the posterior superior pancreaticoduodenal artery. And if that wasn't maddening enough, here we go. We're transitioning to the midgut. Celiac trunk supplies the foregut, and that's going to extend to about the midpoint of the duodenum. After that, it becomes midgut, and its parent artery will be the superior mesenteric artery. And here he is. Superior mesenteric artery gives off branches to the head of the pancreas and duodenum as well. And guess what? They're going to be coming from an inferior pancreaticoduodenal artery, and they are. The anterior inferior pancreaticoduodenal artery and the posterior inferior pancreaticoduodenal artery. So, just remember you've got all 4 quadrants of the head of the pancreas and duodenum accounted for. 2 superior, there's an anterior and posterior. 2 inferior, an anterior and a posterior. Alright, let's move it on. But just before we do, we've got an inferior pancreatic artery that feeds into this nice little network throughout the pancreas right there, and that's also coming from the superior mesenteric artery. So the pancreas and duodenum mark the organs that transition from foregut to midgut, and their blood supply reflects that. Splenic artery supplying them as well, but that's one of the foregut branches, and coming from the splenic, we've got those other branches to the pancreas. Artery to the tail of the pancreas, pretty easy. I'm not going to have you tell me where these transitions occur, so I'll ask you, if I ask you, to identify these close to where they originate. Posterior or dorsal pancreatic artery is the first big one, then the greater pancreatic artery out here, and then the artery to the tail of the pancreas. All right, let's talk clinical importance, and as I've already mentioned, if you're removing a gallbladder, it's absolutely essential to find the blood supply. To do that, you're going to work with the triangle of Callot, or the cystic triangle, and essentially you identify the cystic duct, you identify the common hepatic duct, and you find the underside of the liver, and in that triangle you may have some branches of the right hepatic artery, but you will have your cystic artery. So this is a good way for you to look really, really suave during a general surgical rotation by being able to locate where the landmarks are for your cystic artery there. So now let's take a look at the branching of the superior mesenteric artery. So right here is the main trunk coming off the aorta, just inferior to the celiac trunk. In reality, they're usually quite a bit closer than they're showing in the illustration here, but we've got those inferior pancreatico-duodenal arteries coming off a common trunk here. Then next we have the middle colic artery. Now it's been cut here because it supplies the middle portion of the large intestine, the transverse colon. So we'll see that in a minute, but right now we can see the many branches going to the small intestine. We have jejunal arteries up first with their less complicated arcades and their longer vasa recta, and then a little more further along towards the bottom right of the abdomen we have our ileal arteries with more sophisticated arcades and shorter vasa recta. The exact transition point's not clear. I wouldn't be asking you to distinguish exactly when one stops being one and starts being the other. Our other branches are going to be the right colic artery, primarily to the ascending colon, and the ileocolic artery, primarily to the ascending colon and cecum. So right here, if we can think about a clock face, one way I like to keep these straight is that the ileocolic artery tends to come off at about 7 o'clock, 7 to 8 o'clock here, and then the right colic artery tends to be more like 9 o'clock. The middle colic artery tends to be about noon, or if you prefer 6, it's going to be just kind of right on the midline, and we'll see the other arteries on the other side in just a minute. Now, off the ileocolic artery, we typically have our appendicular artery going to the vermiform appendix, and let's switch it up now and see those other branches. So right here, who's hanging out at 7, 8 o'clock? That's the ileocolic. Who's hanging out at 9 o'clock? That's going to be our middle colic right there. And let's get that plugged in. There we go. So ileocolic giving off the appendicular artery, and 9 o'clock, here's our right colic. Now we've reflected the transverse colon superiorly, and we can see, I'm going to call it noon, even though it's kind of drifting off a little to the left there, the middle colic artery. And I want you to notice, these colic arteries don't just go straight into the large intestine, they feed into this anastomotic network all the way along its interior margin. And for that reason, we sometimes call this whole thing the marginal artery of Drummond, although some people only call this little region here the marginal artery of Drummond. So just be aware, some people have differing definitions of what that actually constitutes, but it allows the blood supply to the colon to be shared between all these arteries that are feeding into it. Now right here at the transverse colon, moving into the descending colon, we transition between the midgut to the hindgut, and the hindgut gets its blood from the inferior mesenteric artery. So there he is, and the inferior mesenteric artery is going to branch into a left colic artery. That's going to be our 3 o'clock on the clock face, and then we're going to have some sigmoid arteries going to the sigmoid colon right there, and then finally the superior rectal artery. Now the superior rectal artery is the last branch off our inferior mesenteric. We'll have some other rectal arteries down here, but they're coming from a totally different source. So just be aware that other rectal arteries are not coming from this inferior mesenteric artery right there. Now once again, variation is the rule and not the exception, but I'm going to test you based on this version. So here's the testable version right here. But because I want you guys to have a pretty good idea about what's going on, just be aware there can be a lot of variations here. In this case, the middle colic artery doesn't really come off as a separate entity. Instead, we have a big anastomotic network from ileocolic and right colic here, fusing with that marginal artery over here, linking the midgut to the hindgut via the inferior mesenteric and left colic branches. Over here, we've got a lot more anastomoses going on, common trunks giving off various branches there. So just be aware, there's a lot of variation in this process. A couple other weird ones. Sometimes you have multiple arcs right here. Instead of one marginal artery, we've actually got two branches covering that. This is sometimes called the arc of Riolan. If that comes in handy for you on a surgical rotation, you're welcome. And then here, big middle rectal artery, no separate right colic artery. These things happen. So just be aware, lots of variations can occur, and then you can have this crazy setup here with every possible branch going in, and there's that arc of Riolan one more time for you. So just be aware, these are things you might see surgically, but that won't be what I test you on. So, arteries are all done. Congratulations. But now, it's time to move on to the veins. Now the good news is that the veins more or less correspond to the arteries, but the drainage pattern is different. So here, starting with our hindgut and moving proximally, we've got a superior rectal vein, joins with blood coming from the sigmoid veins and the left colic vein. So there's our hindgut. Rectum, sigmoid colon, descending colon, all that blood is converging onto an inferior mesenteric vein. But that inferior mesenteric vein does something a little weird. It joins the splenic vein. So the big splenic vein coming from the left side of the body up here receives blood from the inferior mesenteric vein. And then that splenic vein is going to meet our superior mesenteric vein. Now the superior mesenteric vein has all the branches we'd expect, a middle colic vein, a right colic vein, an ileocolic vein, paralleling the arteries. But when the superior mesenteric artery and splenic vein join, they form the hepatic portal vein. And that's the vein that carries all this blood to the liver to be screened, detoxified, etc. Now nearby, we're going to have the right gastric vein and a little branch coming from the distal esophagus that drains into that right gastric vein. That's going to be very important shortly. So just file that away for a moment, right there. The celiac trunk, those arteries don't converge into a single vein. Instead, each one of those daughter veins will tend to go straight to the hepatic portal vein. So right here, right gastromental vein, that's going to go pretty much into the hepatic vein right there. Left gastromental vein, it's going to join the splenic, which is nearby. But right over here, I want you to note those superior and inferior pancreaticoduodenal veins. They tend to all converge onto the superior mesenteric vein, and the two gastric veins, left and right, drain distinctly into the hepatic portal vein right there. Now one more time, see those esophageal veins draining to the left gastric vein? They're going to be important. And there's that hepatic portal. And the hepatic veins are separate. They're coming into the inferior vena cava from the liver. So all the blood from the hindgut, the midgut, and the foregut, all the blood from those organs drains to the hepatic portal vein, goes into the liver to get detoxified, get cleared, get screened, and only then does it go to those central veins that converge, get bigger and bigger, finally draining into hepatic veins. Why do we care? We care because if we wind up compromising the ability of the liver to filter the blood, it's going to start having the blood back up into all those tributaries of the hepatic portal vein. So think about the liver as a coffee filter full of coffee. Normally, water goes through it, it percolates through, boom, at the other side we get coffee. But what happens if I take a bunch of sand and dump that into the area? I might get some drainage still, but I'm going to have a lot of backup of the water sitting on top of that coffee filter that's now full of sand rather than coffee. And that's essentially what's going on in cirrhosis. We've made the flow through the liver more difficult, and so we have that blood backing up into those veins. Now because of that, we wind up with portal hypertension, or high blood pressure inside the portal vein. And blood, like any liquid, is only going to go where it can based on pressure changes. So real quick review. Here again are our branches of the hepatic portal system. Superior rectal vein joins the sigmoid veins, joins the left colic veins, and they're going to fuse into a single inferior mesenteric vein that joins the splenic vein. These are all draining to the portal system. That's why they have portal in parentheses after them. All the branches from the midgut, so right colic, ileocolic, ileal, jejunal, all those guys, middle colic, they're all going to go into our superior mesenteric vein. And when they fuse with the splenic vein, we've got our hepatic portal vein right there. And it is a portal vein. Haha. We all have fun here. And then we've also got branches of the gastric and gastromental veins draining there as well. So these are all feeding into the portal system. There are places where the veins of the portal system come into close contact with veins that drain directly, more or less, to the inferior vena cava. So right here, we have middle and inferior rectal veins that are draining to the internal iliac vein. That's inside the pelvis, but it's going to drain eventually to the inferior vena cava. So we have a spot where the blood that's at higher pressure in the portal system might work its way down, 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 and then start draining into the middle and inferior iliac veins. Over here, there are some small vessels along the body wall for both the ascending and descending colon that are going to drain to the lumbar segmental veins and then to the inferior vena cava, so we can have some backflow of blood through these right or left colic veins into the body wall, excuse me, and then to the inferior vena cava. Right here, this one's kind of funny. We have our falciform ligament and our round ligament of the liver running to the anterior body wall, and there are some small veins that drain to the portal system there. Because of that, those veins can balloon out if they get too much blood traveling in them and push the blood from the portal system out to the umbilicus and then drain to those veins that we saw on the anterior body wall, the ones that are going to go to our superficial veins. So the superficial epigastric vein, those paraumbilical veins going to the thoracoepigastric veins, it can actually push the blood from our liver onto the body wall. And last, and probably most important, we've got some veins in the lower to middle esophagus that are continuous with these small esophageal veins that are draining to the left gastric vein. So normally, this drainage would just go to the hepatic vein or to the inferior vena cava, but if we have portal hypertension, that increased pressure in the portal system is just going to push, 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 and maybe some of that blood will then transition from these lower esophageal portal veins up to these esophageal veins that drain to the azygous system, and then from there to the superior vena cava. So this is super important for this reason. So what we have a picture of here are some distended esophageal veins in portal hypertension. This is looking down the lumen of the esophagus, and we should not normally see these big distended veins. Portal hypertension has caused blood to back up into the hepatic portal vein, and as part of that, it's backed up into the left gastric vein, backed up into the small esophageal veins, and that blood has pushed its way upward into and enlarged those esophageal veins that go to the azygous system. These are medically very concerning because they're thin-walled, they're in the esophagus, they're prone to rupture, and people can indeed exsanguinate or bleed out from their mouth if these veins rupture and all that blood starts coming out the mouth. Here we've got what happens when the blood routes from that umbilicus, so via that falciform ligament, into the umbilicus, and that hepatic portal blood then drains into the thoracoepigastric veins and then to the femoral vein down here or the axillary vein up here. This is sometimes called caput Medusae, or head of Medusa, and if you studied your Greek mythology, you know Medusa had a head full of snakes, which is what people assumed this looked like when they were first describing it. Now, if we have the superior rectal vein draining blood into the middle and inferior rectal veins, that can be one cause of, not exclusively, but a cause of hemorrhoids. So we can have an internal hemorrhoid here that's ballooned out because it's carrying blood from that superior rectal vein and routing it into the middle or inferior rectal veins, and it's ballooned out in the process. So this is one way you can deal with these internal hemorrhoids. You can actually just kind of seal them off with a rubber band. They'll dry up, fall off, etc. So again, hemorrhoids can happen for a variety of reasons, but that is on the list. So we've covered the blood supply. Now it's time to talk lymphatic drainage. And the good news is that lymphatic drainage more or less parallels the vessels that are already there. It's going to parallel the arteries or the veins that are already present along these organs. One exception to that is lymphatics will also just drain to lymphatic channels that they're close to. So lymphatics get to choose to either follow vessels backwards to drain their fluid or to just go to nearby structures that are on the body wall of the diaphragm to do so. So all these nodes can be named for the organ or the vessel that they're close to. So right here, I would call these guys right gastroomental lymph nodes. I'd call these guys left gastric nodes, and I call these guys splenic nodes. But essentially, all the lymphatics from these organs is going to pass through some of these nodes and converge onto a celiac lymph node that's at the base of the celiac trunk. And from there, it's going to pass superiorly through something that's called the cisterna chyli. More on it in just a moment. Likewise, we've got all these pancreatic nodes right here at the tail, the body, the head, and these nodes, along with the ones here on the right side of the greater curvature, so right gastroomental nodes, are going to wind up draining most of their lymphatics to this celiac node right here. So it's going to parallel the blood supply more or less in reverse. One exception to this is the liver. The liver can have its lymphatics drain along the proper hepatic nodes, common hepatic nodes to the celiac node, so it can follow the blood supply in reverse. But because the liver is so huge, it can also have its lymphatics drain to nodes alongside the diaphragm up here, so it can just work that way to get to these phrenic lymph nodes. The main thing I want you to know about that is just that the liver has a variety of lymphatic drainage routes that it can follow, and it's based on either blood supply or proximity. One more important thing about the liver is that it's got a capsule with a very sophisticated plexus of lymphatic channels on its on its surface. So if you take the capsule of the liver off, you're also removing the significant network of lymphatics here. It's called the subcapsular lymph plexus. These pictures are actually made by injecting mercury into the lymphatics and then drawing the results. You can actually see how branched and how significant this is. One cool thing about this is that if you have someone who's administered drugs intraperitoneally, you just put the drugs into their peritoneal cavity, this tends to be where they're picked up and make their way from there into the lymphatic system and then up to the left subclavian vein to get into systemic circulation. One negative is that if you have too much fluid in the liver due to portal hypertension or due to heart failure, you can actually wind up with the fluid in these lymphatics being unable to drain effectively, and that fluid then sweats out into the peritoneal cavity, releasing a bunch of fluid in there, which is called ascites. So ascites is going to be excessive fluid in the peritoneal cavity and this peritoneal cavity, and this is one place that can happen. So the pancreas, as usual, is going to be a bit of a pain because it's kind of straddling the foregut and the midgut. It can drain to both celiac nodes or to superior mesenteric lymph nodes and then head upward. The pancreas, its lymphatic drainage is important because it tends to be an organ that can develop cancer and not give us too many warning signs until that cancer is spread widely. So knowing the visceral pain patterns associated with the pancreas is kind of important, and we'll talk about that in the innervation talk coming up shortly. The rest of the small intestine has its own set of lymph nodes, so we're going to have along the jejunum and the ileum some lymph nodes scattered throughout its mesentery, and that's going to be the structure that creates or carries the blood vessels to and from the small intestine, as well as the lymph that's going to be traveling from the intestine back more proximally. Small intestine is all midgut, from the kind of middle duodenum all the way to the ileum, including some of the large intestine, and so that lymph will drain along mesenteric lymph nodes to eventually reach the superior mesenteric lymph nodes. And remember, superior mesenteric artery is the parent artery to all of this, so all that lymph is going to drain back to superior mesenteric lymph nodes, and from there it just hops up to the next set of nodes involved, the celiac lymph nodes, or it can divert over here to this large bag of lymph called the cisterna chyli. Now, large intestine is similar to the small intestine in that we've got lymph nodes in the mesentery whenever we have one, or along the body wall, and it's going to be roughly paralleling the vessels. So we have paracolic lymph nodes going around the periphery of the colon. We're going to have mesenteric lymph nodes clustered along the arteries. So I could call this the middle colic lymph nodes, the right colic lymph nodes, the ileocolic lymph nodes. But for right now, we're just going to call them all mesenteric lymph nodes because they're hanging out in the mesentery, or what used to be a mesentery, of the parts of the large intestine that are fused to the body wall. And they're going to drain back to either the superior mesenteric lymph nodes, if they're going to be from the midgut, so ileum, appendix, cecum, ascending colon, transverse colon. That lymph tends to go to the superior mesenteric lymph nodes up here, whereas the rectum, sigmoid colon, and descending colon, those mesenteric lymph nodes tend to drain to inferior mesenteric lymph nodes. And lymph from there will then scooch up to the superior mesenteric lymph nodes, which will then scooch up to the celiac nodes or cisterna chyli. So let's talk about that process. It's actually easier than you might think. Once we're back alongside the aorta, we just move upward, and there's a variety of lymph nodes that any bit of lymphatic fluid can flow through, but the tendency is for it to go superiorly. So inferior mesenteric lymph nodes drain or receive lymph from the hindgut, superior mesenteric lymph nodes receive lymph from the midgut, and these celiac nodes receive lymph from the foregut. Once we're in the inferior mesenteric nodes, we just drain along these lumbar or para-aortic nodes to get to the superior mesenteric. From there, we drain to the celiac, or we go to that special little bag called the cisterna chyli. So lumbar nodes will be the term we use for these nodes that are somewhat parallel to the aorta and not specifically at the junction point where these arteries leave the aorta. All right, so let's take a quick look here and see what we've got on our paired arteries. That's right, we just spent all that time on the unpaired arteries. Now it's time to actually hit the paired ones. And I have some good news. They're pretty simple. They're going to be on left and right, an inferior phrenic artery going to the underside of the diaphragm, there and there. We're going to have off of those some superior suprarenal arteries, also called superior adrenal arteries, because they supply the adrenal gland. And the adrenal gland, for being such a small structure, has 3 separate blood supplies. Off the aorta, we have middle suprarenal arteries, and then we've got a renal artery on the left and right, and those give off inferior suprarenal arteries. So just be aware, we've got the inferior phrenic to the diaphragm, the renal arteries to the left and right kidneys, and off of the inferior phrenic, the aorta, and the renal artery, we have 3 separate sets of suprarenal arteries going to that gland. Also off the aorta, just inferior to the renal arteries, we have the left and right gonadal arteries. So male, testicular artery. Female, ovarian artery on the left and right, and they're both direct branches off the aorta. Then we get to our next paired branch, and that's the end of the abdominal aorta, the left and right common iliac arteries there, which then split again into an internal iliac going to the pelvic organs and deeper structures of the pelvis there, and the external iliac artery, which is going to supply blood to the body wall and become the femoral artery and supply almost all the blood to the lower limb thereafter. Along the way, we have multiple lumbar segmental arteries coming off the aorta, as well as one coming off the common iliac artery traveling around this way. At the we're going to just call it the crotch of the aorta, right here where it splits into the common iliac artery on the left and right, we have a single midline artery going right down the inferior lumbar vertebral bodies and the sacrum, and that is the median sacral artery right there. And as far as the paired vessels go, we've got more or less the same setup draining to the inferior vena cava. So right here we have internal iliac and external iliac veins joining to form the common iliac vein on the left as well as on the right. Those fuse to create the inferior vena cava, and the inferior vena cava is going to get blood from the right kidney, right renal vein, and left kidney, left renal vein, which crosses the aorta right there. Now, one interesting thing about the inferior vena cava is that it's on the right side of the body, and so the right gonadal vein, testicular vein, or ovarian vein will drain straight to the inferior vena cava, as will the what's called the right suprarenal vein that's going to be coming from the adrenal glands. So if it's on the right, it goes to the inferior vena cava. But because it's shifted there to the right, these veins on the left side, like the left ovarian vein or the left testicular vein don't transition to the IVC. Instead, they drain to the left renal vein first, as does the left suprarenal vein, and the blood from those structures then flows through the left renal vein to get to the inferior vena cava right there. And we've also got branches from the diaphragm, so we've got some inferior phrenic veins draining to it right there. And the inferior vena cava, just before it leaves the abdomen, gets blood from the liver, from those hepatic veins. So all the blood from our midgut, our foregut, our midgut, and our hindgut goes to the liver through the hepatic system, and once the liver's drained and filtered and screened all that blood, then it gets dumped into the inferior vena cava via the hepatic veins.